Hello, everyone, and welcome back to our IPC in Action podcast.
Hello.
Hello. So, I am Fran, one of the infection control nurses.
And I'm Jen. I'm one of Fran's colleagues. I'm one of the senior infection control nurses in the team. So today we are going to talk about a very interesting little organism.
I find it really interesting,
I do as well. I do as well.
Well, don't love it, but you know
So
what I mean.
it's called Group A Streptococcus. It's unhelpfully sometimes referred to by a few different names,
Yes.
which can lead to some confusion. So you'll sometimes hear it as Group A Streptococcus. There's also GAS, which is just that sort of acronym abbreviation of it. Sometimes Group A Strep, sometimes Strep A, and sometimes Streptococcus pyogenes.
Pyogenes, the words we all need to get right.
Yeah, exactly. So it's a bacterium and it can colonize or just live harmlessly in the throat, skin, or anogenital tract of people. It's spread through the sort of close contact between individuals. If it is in somebody's throat or in their sort of airway, in their lungs, it can also spread by those respiratory droplets as well. It can cause quite a diverse range of skin, soft tissue, and sometimes respiratory tract infections. So I think one of the most sort of common infections I know that I think of when we're talking about Group A strep is tonsillitis.
Yeah.
I know I used to get it all the time as a kid.
Yeah, me too. Yeah.
It can also cause pharyngitis, scarlet fever, which we're going to cover in a little bit more detail in a moment. It can also cause impetigo, which are those sort of painful sores that you can get around your mouth. It can cause erysipelas, which is also easy to confuse with cellulitis. And I think erysipelas and cellulitis are those conditions that can quite quickly go from what may have started as like a little graze on your leg to a pretty significant and severe infection. So it's not to be ignored.
Definitely.
And finally, pneumonia. So occasionally these infections can be extremely severe. One thing we know about Group A strep is it is quite easy to kill.
Yeah.
It is sensitive to most of your penicillins. It's a gram-positive bacteria, and most of your penicillins are very effective at destroying this organism.
Which is fantastic.
Yeah, exactly. That's one helpful thing, isn't it?
Exactly. So we'll start off by covering scarlet fever. So obviously it's an interesting name, but actually a fact that we found out not that long ago is sometimes it's called scarlatina.
Yeah, so I did know this. It was brand new information.
I didn't know that.
But yeah, it's most sort of commonly seen in children, and it's characterised by a rash, which quite often accompanies a sort of sore throat, red and swollen tongue. Initially, there's a sort of quite commonly a white coating on the tongue. When that comes off, it's described as a strawberry tongue. That sort of texture and that visual appearance of a strawberry, where it's sort of slightly peppered with raised dots.
Dimpled,
and flushed cheeks. Yeah. That's the most sort of classic sign of it. Can be confused with measles.
Yeah.
So it is just, important to think of the difference between the two.
Differentials.
Most commonly a childhood disease and normally seen roughly between the ages of 2 and 8 years. It used to be considered quite a dangerous disease. It's now much less serious as we have very good antibiotics that can get rid of it.
We have seen, there has been a pretty big rise since 2014 in terms of the number of cases in England. So it's gone from around 15,000 to 30,000 cases currently diagnosed each year in England. So I guess, being a childhood infection, nurseries, schools, etc.
Absolutely. Well, and it also impacting our own staff if their children are off poorly with it.
Yeah.
I'm not sure either of my children have ever had it yet, thank goodness.
Hopefully not.
So it's highly contagious and it's spread by close contact with someone carrying that bacteria. So it can take around 2 to 5 days to develop symptoms after exposure to this bacteria. So we would sort of consider that roughly the incubation period. Tends to be more common in the colder months and spring, and the treatment consists of a course of antibiotics.
Yeah. So as Jen said, it's spread by the mucus and the saliva of infected people. So it can also be caught by drinking glasses, plates, utensils. It's quite a hardy little bug in that respect.
More sort of like environmental contamination.
Yeah, exactly. So our main kind of tips on that is to obviously be washing your hands more often.
We love giving that advice.
Oh gosh, and everyone knows that we do as well. Not to be sharing utensils with an infected person, washing or disposing of handkerchiefs or tissues by an infected person, and being aware, obviously, that you can catch scarlet fever by inhaling the contaminated droplets of someone that has a cough or sneezes if they are infected.
Yeah, absolutely. It's important to consider that if you think yourself or your child may have scarlet fever, that you do reach out for help. The cases can get better by themselves, but quite often this does require treatment with antibiotics. This will also massively reduce your period of infectivity. Yeah. So if you are treated with antibiotics, within a couple of days, you would be feeling significantly better and that period of infectivity will come down significantly. Whereas if you're not treated with antibiotics, that infectious period could go on for at least 2 to 3 weeks. So it is vastly increased.
Yeah.
And obviously you're then increasing the risk of onward transmission with it. So if you're concerned, contact your GP or contact NHS 111 to seek that advice and get appropriate treatments as needed.
Professional guidance. So some of the symptoms that you might see for first sort of onset of scarlet fever might include sore throat, a headache, fever, nausea, vomiting. So obviously all of those common types of symptoms that we see in a lot of infections. So that's why it's important to, if you are concerned, to seek help from your GP or NHS 111 because of those kind of differential diagnoses.
Yeah. One of the classic symptoms as well of scarlet fever is a rash. It quite often starts on the rash or the abdomen, and it can have this sort of textured feel, a bit like sandpaper. And that texture is classic, but it may be less visible on darker coloured skin. So it's just making sure that that appropriate assessment is taking place, that it may not appear as visible on darker skin. So to make sure that you're carrying out a thorough assessment so that any symptoms aren't being missed and potentially miscategorized.
So that was a kind of roundup of scarlet fever.
Very briefly, in a nutshell.
Very briefly. So next we're going to be talking about invasive gas, as it were, or eye gas, which we call it. Yeah. So eye gas is another infection which is caused by Group A strep, which is much rarer than scarlet fever. So it occurs when gas is isolated from a normally sterile body site. So this might be the blood, spinal...
spinal fluid. You certainly don't want it in your CSF.
No, absolutely. So that can be a cause of much more serious infection.
Yes, it
which
can.
We do see.
Yeah,
we do see it.
And you've probably seen in the news, there's been a lot more media hype around it regarding eye gas cases in children, which unfortunately led to quite a few deaths, actually. So those cases have now sort of dropped off. It's being seen a lot less. I think it's also in the media a lot less. So it's a little bit less sort of fear-mongering.
Exactly.
You hope. Both eye gas and scarlet fever are notifiable diseases. Now, you might hear us talk about notifiable diseases. The reason we talk about it is if it's notifiable, it means we have to tell other people. Yeah. We're not going to keep it in-house. We need to tell the health protection team, who are a sort of arm of the UK
Health Security Agency.
Yeah, I always get the letters wrong.
The UK HSA.
UK HSA. There we go.
Which used to be Public Health England.
Exactly.
Just for clarification. So in that respect, we would say to the clinician looking after the patient that they need to complete a notification of infectious diseases form, or a NOIDS form, which can be found on the internet, and there's lots more information about it on the internet and on the government website as well. So make sure to take a look at that, because there's also a list on there of the notifiable infectious diseases as well, just for your own kind of knowledge in that respect.
And it's a tool that that's used to just sort of monitor potential outbreaks, like, is the Southwest spiking in gas cases right now, and so on and so forth. So it's another sort of surveillance tool used to monitor infections in certain areas. So something quite exciting, Fran, necrotizing fasciitis.
Yes, I've always found necrotizing fasciitis a very interesting topic.
It is. It's also got an element of fear mongering from the media 100%. Around it, hasn't it?
Yeah, definitely. I have had patients that I've seen before where I've said, we've isolated Group A strep in the wound, and they said, have I got the flesh-eating bacteria?
Exactly. Yeah.
So there's obviously the difference that necrotizing fasciitis, or as some people call it, neck fash, is caused by Group A Streptococcus.
Yeah. Nearly always caused by Group A strep.
Exactly. And
so this is a very sort of severe version of it, and it's interesting. It can be caused. So if say for instance you have an abrasion or a cut on your leg, sometimes necrotizing fasciitis presents as a disproportionate amount of pain, depending on what you may be able to visually see. Fevers, redness, swelling, your sort of standard signs of infection. And neck fash does need to be ruled out quite quickly.
Absolutely.
As it can quite often lead to pretty heavy surgical intervention.
Absolutely. Correct me if I'm wrong, it's more common in men, isn't it, necrotizing fasciitis?
I don't know the answer to
sorry,
that.
I thought that was something that I'd heard before. So that's something that Jen and I both need to go away
and
have
we need
a
to go
look
away
at.
and do a bit of revision on that one.
I think
wasn't aware of that one.
Because Jen used to work on DCC, I used to work on a surgical unit. I've seen some cases of necrotizing fasciitis. It's not nice. It's really not nice. So that's why we need to get it diagnosed quickly and treated quickly to get rid of this nasty little bacteria.
So treatment for Group A strep, it's not nice, but it's highly treatable.
Yes.
So as sort of mentioned, a lot of your penicillins will cover Group A strep. As a gram-positive bacteria, they do not like penicillins, which makes them our favourite tool. We need patients isolated when they have a Group A strep for the reasons that we've mentioned. It's quite spready. It's quite easy to transmit. We don't want any onward transmission. So for that reason, we want patients with Group A strep isolated. But
the isolation is that they need to be isolated for a minimum period of 24 hours while they complete 24 hours of antibiotics. Because that 24 hours of antibiotics will cover the kind of acute stages of that infection. And then post that, if you feel that you need to move them out for whatever reason, then you can do. But as we say, it's a minimum. So
minimum of 24 hours of appropriate antibiotics. So it's making sure that those antibiotics cover streptococcus.
Exactly.
And those discussions can be had with your senior medical colleagues, with your pharmacists, and with the on-call microbiologist if needed.
So the other thing that we would obviously look at, another favourite of ours, is the PPE that you would use.
We love PPE.
So as we said, because it can be transmitted by sort of direct contact, therefore we would suggest wearing an apron and some gloves, and obviously effective hand hygiene, as we always say.
Yeah. And I think if somebody's also got it as potentially like a respiratory infection, if they are sort of very spluttery with that, you may choose to wear a mask and visor as well, just to reduce the reduce that risk of onward transmission.
And a surgical face mask will be absolutely sufficient in that. So again, it's all just about that risk assessment that you're taking at the beginning of seeing this patient.
Yeah. Cleaning. So our green universal wipes will kill streptococcus.
Yes.
So they are perfectly acceptable to use when you're cleaning equipment, when you're cleaning down any sort of ambulatory equipment that's moving between patients. We do want to make sure that that is cleaned.
Yeah.
If you're imagining a finger going into a SATS probe and that person is covered in Streptococcus,
Exactly.
you don't want that SATS probe going from patient to patient to patient.
Yeah.
So it's making sure that you're cleaning down equipment in between use.
Yeah, getting really kind of in there, like with the SATS probes.
Get in those
especially,
crevices.
You get in there with your Clinell wipes because those bacteria will be lurking around if they're not cleaned properly. So please do your utmost in terms of thorough cleaning when moving equipment from place to place.
Hand washing with soap and water. Equally, alcohol hand gel is also incredibly effective against Streptococcus.
Definitely.
And when they vacate a bed space, we would request an amber clean is done on that bed space, please, just to ensure we are reducing that bacterial load as much as possible for the ever-present reason of reducing onward transmission.
Exactly. So that was a
whistle-stop
roundup.
tour.
That was a whistle-stop tour and a good old roundup of Group A Streptococcus. We hope that you found that helpful. I mean, personally, we've seen quite a few cases recently, I would say. So we felt it was an important topic to cover. Hopefully you have found it interesting.
Yeah, just as a sort of preface, there are other groups of Streptococcus. And just to make it clear, we are only covering Group A in this particular one. We may cover a Group B one at a later stage, but we definitely need to do a little bit of revision and maybe call on some of our maternity colleagues for that one.
Absolutely. Well, look forward to that one.
Yeah.
And Jen and I need to do a bit of research into whether it's more common for men
neck
to get
fash.
neck
Yeah.
fash.
Yeah. We will report back on that.
Yeah, we will. But as usual, you are very welcome to contact us via the usual routes, via email, our acute ICN email address on the global address book. Hopefully you'll see us out and about, and hopefully you're enjoying these podcasts and any of our newsletters that we're sending out as well. So yeah, if you have any issues, any queries, you want help with anything, please don't hesitate to contact us. We're very happy to help. And we will see you next time.
Yeah, thanks for listening.
Thank
Bye.
you. Bye.